Good afternoon, one and all. I'm going to talk about the hemodynamics which happen during liver transplant surgery. Anesthetic management of these patients presenting for liver transplant is quite complex and often challenging because the hemodynamic disturbances which happen are abrupt and often catastrophic. A thorough understanding of the pathophysiology is essential because they are high-risk surgical patients, so understanding the nature of disease is important, and the surgical factors can again compromise your hemodynamics because it involves clamping and unclamping of major vessels, and then I'll tell you about how we tackle them. So we've dealt with the pathophysiology of individual organ systems in very great detail since morning. I'll not go into the full details. Just in brief, the systemic vascular resistance is low. The central blood volume is constricted. The non-central blood volume, where the splanchnic blood volume is quite enlarged, and you have a hyperdynamic circulation. So this is to show the splanchnic steal which happens in patients with end-stage liver disease. You can see the arterial and venous steal. And there is a distinct entity called the cirrhotic cardiomyopathy, which is often latent and gets manifest when the patients are exposed to stressful situations like surgery. So there's both systolic, diastolic dysfunction and electromechanical abnormalities. Going on to the stages of surgery, in the pre and hepatic phase, we start off with the anesthetic induction. Most of the induction agents will cause a reduction in SVR, so your cardiac output can fall at that period. And when the abdomen is open and the ascites is decompressed, again, there's a potential for hypovolemia at this point. So significant fluid shifts happen, and bleeding can happen quite extensively sometimes. It's because of the portal hypertension, sometimes when there is previous abdominal surgery, presence of tips, all of these can cause extensive bleeding. And of course, the surgical manipulation, which can cause twisting of the cava and IVC compression. So all these can cause a decrease in cardiac output. In the anhepatic phase, there is a reduction in venous return because of the various clamps. I'll tell you in a little more detail in the next slide. There's ongoing bleeding, worsening coagulopathy, more fibrinolysis, acidosis, and hypothermia. All this can further cause a decrease in the cardiac output. And then comes the critical stage when the graft gets revascularized, the reperfusion phase, when the cardiac output actually increases, and sometimes catastrophes can happen at this point. Briefly about bacterial translocation, which can cause significant hypotension when the abdomen is open. This has been extensively evaluated. So presence of bacterial DNA means the systemic hemodynamics become more aggravated, more vasodilatation when it happens. So this supports the use of gut decontamination in patients with end-stage liver disease, and there have been promising results in reduction of gram-negative infection in those patients who are exposed to SDD following liver transplantation. So briefly about the surgical advances which have contributed to stable hemodynamics during transplantation. Initially, it started off with a complete caval clamp. Surgically, it was quicker and simpler. The anastomosis was simpler, but we had problems with severe hypotension. A vena caval clamp can cause a reduction of cardiac output to up to 50%. So, and also there was a potential for renal outflow obstruction and renal injury. And then the advances happened, the veno-venous bypass was introduced, hemodynamics was fantastic, renal venous drainage was also adequate, and there was less intestinal engorgement. But the problems, again, of having an extracorporeal circuit and technical complications from access-related problems. Then came the piggyback technique. Very less hemodynamic stability, it's very good, renal venous drainage is maintained. But the problems is it's technically a little more challenging. But there's still a problem of intestinal engorgement because of portal occlusion. This can be alleviated by using a portocaval shunt. So then comes the critical stage, reperfusion, the graft being revascularized. Initially, when the clamps are released, there is an improvement in venous return. Thereafter, when the blood from the graft mixes with the circulation, it's really cold, contains potassium and adenosine, which is a preservative in UW solution. All this can cause myocardial cooling, bradycardia, and dysrhythmias. So cardiac output rises, and SVR again continues to fall for the rest of the period. This is to show how basically the changes which occur at reperfusion are an increase in cardiac output. As I said, it's gone up from 5 to 15.7 as it's shown here, and the PA pressures also rise, but the SVR alone falls. PRS is a significant thing. It was initially described by Agarwal in late 1980s. He basically described the syndrome. PRS was defined as more than 30% decline in the mean arterial pressure compared to the baseline before revascularization. It should last for more than a minute during the first 5 minutes of graft reperfusion. Initially, it was thought it was only the cold fluid which is causing the PRS, but lots of mediators have been found, the complement mediators, activation of the bradykinin-kinin system, which causes decrease in systemic vascular resistance. Other factors are minor contributors of hypotension. So going on to the management, optimization of hemodynamics is a cornerstone. Adequate volume management during liver transplantation is a cornerstone for outcome, not only for graft survival, but also for patient survival. Tissue hyperperfusion is a portender of poor prognosis. It heralds the onset of multiple organ dysfunction syndrome. There has to be a real delicate balance between preload optimization and avoidance of pulmonary edema. As I said earlier, the central blood volume is too low, so you have very little room to play around. So what do? Fluids or vasopressors. We still have to maintain the perfusion pressure for vital organs. Transfusion practices, Dr. Mallet had described in detail about transfusion, the problems associated with transfusion, and in the olden days when transplantation surgery was started, it was associated with massive blood loss. Now we've progressed significantly because of advancements in surgical techniques and also better understanding of pathophysiology by the anesthetists. So blood transfusion per se is independently associated with poor patient survival. How do we tackle it? How do we get the transfusion rates low? This study again was explained in detail by Dr. Mallet. Having a low CVP is very advantageous. Evaluated. Having a low CVP, it reduces your portal flow, significantly reduces of bleeding and the transfusion rates. No complications were noted in terms of renal or neurological issues. So essentially the key is maintaining your pressures with a low CVP and vasopressors. What do we choose? Phenylephrine has been evaluated again. Intraoperative infusion of phenylephrine, when prophylactically, it increases your vascular resistance. The problems I said was reduced vascular resistance in these patients with a hyperdynamic circulation. So use of phenylephrine increased the vascular resistance and also decreases the portal blood flow. Therefore, your bleeding is decreased and the progression of lactic acidosis is also heralded. The same group, Luke Massicot et al., the Canadian group, they tried a low CVP approach with a phenylephrine infusion. Phlebotomy and a phenylephrine infusion significantly decreased the bleeding rates. In fact, in their group, the transfusion rates were close to 0.4 units of packed cells per patient, which is very good. And there's been significant interest in the use of terlipressin and OLT following the benefits it's offered in hepatorenal syndromes. So splanchnic vasoconstriction and redistribution of blood into the central blood volume, it is very good. This is what we want. So this has been evaluated in various studies. Another advantage of using terlipressin is it enhances catecholamine sensitivity of the myocardium, which is very depressed because of the cirrhotic cardiomyopathy. So terlipressin infusion significantly reduced your portal vein flow, improved systemic vascular resistance, and the mean arterial pressure. The concern of splanchnic hyperperfusion has also been evaluated, and it is found that it does not cause much of splanchnic hyperperfusion. So strategies we have at reperfusion are, you can either preemptively manage them or react when it happens. Preemptively, you can give a calcium bolus because these patients are prone to have hypocalcemia. Long periods of anhepatic phase, there is citrate accumulation because it's not cleared. So giving them a calcium bolus maintains the myocardial sensitivity. And also acidosis is a problem. Giving some bicarbonate helps at this point. It enhances the responsiveness of the myocardium to vasopressors. Reactive, when it happens, when you see a fall in blood pressure, you can give a bolus of epinephrine or phenylephrine. Experimental evidences of use of methylene blue as well. Now the bolus epinephrine you can give in 10 mics increments. There are concerns that it can cause problems, but actually it doesn't because of the chronotropic incompetence. 10 mics of epinephrine doesn't cause much harm. It gets blood pressure back to normal levels. The neohepatic phase, from now on, the hemodynamics is going to depend on the graft function. If the graft takes up well, it's all going to be normal. If the patients have persistent low systemic vascular resistance, you try an infusion of alpha agonist like norepinephrine. It just works very well. When there is evidence of low cardiac output as well, you try epinephrine infusions. There's a potential for right heart failure in these patients because of two things, the low central blood volume, as I said, and the diastolic dysfunction. With the caval clamps, when we are giving too much of fluids in the anhepatic phase, not knowing what it's doing, when the clamps are released, there's a big fluid overload to the heart, and the right heart starts failing. So that needs to be managed with epinephrine, careful monitoring, some amount of nitroglycerin and/or dobutamine. And also, you have to maintain adequate plasma viscosity, which is essential to maintain hemodynamic stability. The catastrophes which can happen are intracardiac arrest. They can be because of post-reperfusion syndrome, or intracardiac thrombus causing pulmonary thromboembolism, and rarely bleeding as well. We need to be prepared to handle all of them. So the study showing the outcome and predictors of PRS, the Canadian group, they showed 25% incidence of PRS. The predictors were absence of a portocaval shunt and the duration of cold ischemia. And it was also shown that patients who had developed PRS displayed more postoperative renal failure and lower early survival. In LDLT scenario, the severity of liver disease in the recipient and graft steatosis may be risk factors for PRS. And there's another finding, the evidence of LV diastolic dysfunction in a preoperative echo and prolonged duration of cold ischemia also can cause poor early outcomes of patients following OLT. This again has been tried, prophylactic vasopressors, giving epinephrine and phenylephrine for prevention of PRS before the clamps are released. Again, that seems to work out very well. It avoids the occurrence, significantly reduces the occurrence of PRS, and also vasopressor requirements after transplantation. But overall, it does not affect the mortality or the ICU stay. It just reduces the occurrence of PRS. Intraop cardiac arrest, again, it's been retrospectively studied in various groups. The incidence is between 1.5 to 5%. The most common cause was PRS and bleeding. There is an incidence of intracardiac thrombus in 35% of the patients. Just to show the survival following intracardiac thrombus. Echocardiogram finding showing a thrombus inside the RA. So incidental intracardiac thrombosis, the incidence is 1.9%. Use of TE allows easy identification. This was a study by Golgorsky et al. 7 patients had intracardiac thrombus followed by pulmonary thromboembolism and RV dysfunction. The significance of this is not known because some of them can progress to cause massive pulmonary thromboembolism and RV dysfunction and cardiac arrest, but majority of them settle down in 30 minutes. So managing them, supporting the RV function at this point with vasoactive and inotropic agents and optimizing the preload is the mainstay of therapy. Any interventions like thrombectomy or use of tissue plasminogen activator can cause high complication rates, and they should only be reserved for selected patients with life-threatening pulmonary thromboembolism. This is about the incidence of pulmonary thromboembolism. The incidence is 4%, and heparin infusion was used. The mortality when a pulmonary thromboembolism occurs intraoperatively is around 30%. So the most significant thing is monitoring. So as I said, adequate volume management here is a key for successful outcome. So how do you monitor the appropriate fluids which we're giving. When liver transplantation started, we started off with the traditional gold standard method, pulmonary artery catheter monitoring. The preload variables were measured by pulmonary artery catheter. Then came the various reports of the complications inherent to the insertion of pulmonary artery catheter. So various other techniques were tried. The transpulmonary indicator dilution methods, like the PICO monitors, are gaining real popularity. And now we know that the correlation between intrathoracic blood volume index and the cardiac index and stroke volume index is significantly better than the pressure variables like CVP and pulmonary artery occlusion pressure with the cardiac index and stroke volume index. So it's more reliable indicator of preload than pulmonary artery occlusion pressure during liver transplantation. Then the role of transesophageal echo. I would say this is the best monitor in OLT because it's real time. It gives a continuous monitor of cardiac output. You can not even, it's just not a number which you see as in the other monitors. You can see the contractility for yourself. It also measures LV end diastolic area, which is the gold standard for preload estimation again. It can tell you the exact changes which can occur during PRS. The rest of all are presumed things like it can cause hypertension and all. Here it can definitely tell you what exactly is causing the post-reperfusion syndrome. It can also pick up air embolism, thromboembolism, and it is very useful in the management of patients with unrelated cardiopulmonary disease. There's a concern with the use of transesophageal echo in these patients is the presence of esophageal varices. There's a big group which studied the problems associated with TE, and they have concluded that it can be performed without serious bleeding risk in patients with grade 1 or grade 2 esophageal varices. And the group, Klepp et al., they found only 0.3% incidence of bleeding complications in patients with significant esophageal varices. So, in summary, for proper management of patients during liver transplantation, a thorough knowledge of pathophysiology is important, appropriate fluid management, just the right preload, avoiding venous stasis, having transfusion triggers, not correcting coagulation pre-op, and the right monitoring will take the patient safely through the transplant. Thank you.